Welcome. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology here at the Cleveland Clinic. I'm welcoming you to this interactive case discussion on liver disease and psoriatic arthritis as part of our comprehensive educational initiative on psoriatic arthritis. I am absolutely delighted to welcome back Dr. Dimitrios Vassilopoulos, Associate Professor of Medicine at the Athens University School of Medicine. Dr. Vassilopoulos is a longtime collaborator of mine on many different areas, and he is one of the most, if not the foremost, rheumatologist with formal hepatology training in the world. He has contributed mightily to the peer-reviewed literature on the liver and rheumatic disease, particularly in studying the pathogenesis, detection, and management of chronic hepatitis B and C in rheumatic disorders. So, Dimitrios, welcome to the program.
Right. I'd like to thank you for the introduction. My name is Dr. Dimitrios Vassilopoulos from Athens University School of Medicine from Athens, Greece. And we're going to talk today about liver disease and psoriatic arthritis based on a real case. This is a 54-year-old male with history of mild skin psoriasis for 15 years who presented with oligoarthritis involving his right knee, left ankle, and third PIP joint for about 4 months. He did not have any significant past medical history, and he was just taking non-steroidal anti-inflammatory medications for pain control. He said that he was drinking 1 to 2 drinks per week. He was not a smoker, and he was obese with a body mass index of 32 kilograms per meter square. So the patient was scheduled to start methotrexate for his joint and skin disease. So if we look at the next slide, what is the appropriate test that you should perform before starting methotrexate in patients with rheumatic diseases? A, do you check just aminotransferases, AST and ALT, aminotransferases and hepatitis B serology, aminotransferases, hepatitis B and C serology, or you add to all this an ultrasound of the liver? If we go to the next slide, we can see what are the recommendations, the official recommendations for rheumatic patients. I would like to mention that there are no specific recommendations made for patients who have psoriasis or psoriatic arthritis. So if you look at the ACR recommendations back from 2008, they recommended that you check aminotransferases, AST and ALT, and you consider screening for hepatitis B and C only if there are risk factors present, like IV drug use, multiple sex partners in the last 6 months, or for healthcare personnel. And what about the most recent 3 recommendations for the use of methotrexate in rheumatic disorders? They also recommend AST and ALT, and they go and they suggest to consider the hepatitis B and C serology. So in this case, the patient was started on methotrexate at 10 milligrams per week per dose for 1 month. That was then increased to 15 milligrams per week, combined with folic acid taken by mouth 1 milligram per day. At that point, no screening for hepatitis B or C was performed. So the patient was started on methotrexate, and the next question is, once you start methotrexate, how often do you check the AST and ALT levels? One possibility is to do that every 2 to 4 weeks for the first 3 months, and then every 2 to 3 months. Do it every 3 months from the beginning. Do it every 3 months for the first 6 months, and then every 6 months, or you can do that every 6 months. So again, if you look for official recommendations regarding liver monitoring during methotrexate treatment, As you can see, there is some variation here. If you look at the older recommendation from the American College of Rheumatology, they recommended that for the first 3 months you check it every 2 to 4 weeks, between 3 and 6 months every 2 to 3 months, and after the 6-month period every 3 months. The most recent multinational recommendations for methotrexate use, it says that you can do that every 1 to 1.5 months until a stable dose is reached, and then the interval is increased to every 1 to 3 months. So the patient showed a very good clinical response of his joint and skin disease, and the dose was continued at 15 milligrams per week. Initially, the levels of ALT were checked every 3 to 6 months, and they remained within normal limits. So after 2.5 years later, while the patient had received already a total dose of 2 grams of methotrexate, during regular monitoring, his transaminases were found to be elevated. His AST was 50 with the upper limit of normal of 40, and his ALT was 71. So the levels were increased less than twice the upper limit of normal. So if we go to the next slide, the question is, how often does that happen in patients with rheumatic diseases? And more specifically, how often does that happen in patients with psoriasis or psoriatic arthritis? We should say from the beginning that we have more data available for rheumatoid arthritis, since we have longer experience with this medication now for about 30 years. If in the most recent review of all published studies in that topic for rheumatoid arthritis, there were about 20 studies involving almost 2,000 patients. You can see that a slight increase in ALT levels occurs in about half of the patients, but only 7% of these patients finally discontinue the drug. If you look at the percentage of patients who have more than 2 to 3 times the upper limit of normal increase in the ALT levels, that occurs in about 17% of the patients. And among these patients, 12% had to discontinue the drug. So although this occurs often, it's, I would say, a rather rare reason for discontinuing the medication. So what is more important, though, it's not how often do the liver enzymes increase. The question is how often do these patients develop severe liver fibrosis. If you look at the same review from 2009, if you look first in rheumatoid arthritis patients on the left, you would see that you can see that less than 2% develop severe fibrosis or cirrhosis after a long period of time, and this is based, of course, on liver biopsies. And the same probably is true for psoriatic arthritis. Probably the rate of severe fibrosis and cirrhosis is a little bit higher, but the difference is not significant. But you have always to be cautious looking at this data, because if you look, for example, in patients with rheumatoid arthritis on the right, who had liver biopsies before methotrexate initiation, you can see that about 10% of these patients had already mild fibrosis or even cirrhosis. And more importantly, if you look to the proportion of patients, the small number of patients who had serial liver biopsies, there was no evidence that a significant number of patients progressed to cirrhosis. And in a more recent study of 54 patients with psoriatic arthritis who received methotrexate for about 6 years and had the liver biopsy, you can see that these patients received about 4.5 grams cumulative dose of methotrexate. And more importantly, about a third of these patients were either obese or had diabetes mellitus. And it's important to note that none of these patients had advanced fibrosis or cirrhosis, and about 15% of these patients had already fatty changes in the liver biopsy. And there was no significant correlation in this study between ALT elevation and the presence of mild fibrosis. So these are reassuring data, of course. And the next question is, how good is the correlation between an elevated ALT that one can find during monitoring and the possibility of developing severe liver fibrosis. I would say from the beginning that the data regarding this issue are rather limited, but there are two main points that I would like to make. First, if you look at patients who have persistently normal ALT levels, the negative predictive value for an abnormal liver biopsy is very high. That means that if you have a patient who has persistently normal ALT levels, the possibility that he has or she has liver fibrosis over a long period of time is rather low. On the other hand, the patient who is demonstrating elevated liver enzymes during monitoring does not mean that he has liver fibrosis. And the reason for that is that there may be other factors that could cause an elevation in the liver enzymes, and we will talk about this in the next slides. First of all, we have to remember that mild elevation of ALT levels is not uncommon in the general population. In a recent study, it was found that about 10% of asymptomatic U.S. adults had a mild elevation of liver enzymes. And the other thing you have always to remember is that there is a considerable variability in the levels of AST and ALT. For example, in patients in a big study who had who had mild elevated AST and ALT levels, when these levels were checked 2 weeks later, about 1/3 of patients had normal values. And that shows us that sometimes you can have transient elevations without a clinical significance. Now, if you look at the general population, by far the most common cause of ALT elevation is fatty liver, what is now called non-alcoholic fatty liver disease, which includes steatohepatitis. And what does that mean? We know that NAFLD, the non-alcoholic fatty liver disease, means that the patients have in their liver more than 5% of macrovesicular fat, what we call steatosis. A proportion of these patients can have steatosis and inflammation and fibrosis, and this is called NASH, or non-alcoholic steatohepatitis. How common is that? This is very common. If you look at recent studies from the U.S., about 1/3 of the population has fatty liver, and among them about 10% have non-alcoholic steatohepatitis. As I said before, this is the most common cause of elevated aminotransferases in the general population, and usually these patients have some abnormalities of what we call metabolic syndrome. That means either abdominal obesity, elevated triglyceride levels, low HDL levels, hypertension, and hyperglycemia. How do you diagnose fatty liver? I think the most easy way to do that in a sensitive and specific way is the ultrasound of the liver, but if you would like specifically to look for inflammation and fibrosis, to look for steatohepatitis, you have to do a liver biopsy. There are some data the last few years using non-invasive methods of estimating liver fibrosis like transient elastography, but we do not have adequate data in our patient population. And why is that important? Because we have to remember that although non-alcoholic fatty liver disease does not progress usually to cirrhosis, this is a rare event, as we can see in this recent review by Torres and al., about 10% of patients with non-alcoholic steatohepatitis can progress to cirrhosis over a period of 15 years. So this is very important when we consider the progression to cirrhosis or fibrosis in patients who receive methotrexate. Second point that I would like to mention, to make, is that patients who have psoriatic arthritis have more often metabolic syndrome or obesity compared to other patients with rheumatic diseases like rheumatoid arthritis or ankylosing spondylitis. In this recent study in arthritis care and research, you can see that about 40% of patients with psoriatic arthritis had metabolic syndrome, compared to 20 of rheumatoid arthritis and 10 of ankylosing spondylitis. About 30% of these patients had obesity, compared to 15% of patients with rheumatoid arthritis and ankylosing spondylitis. So it appears that metabolic syndrome and obesity are more common in psoriatic arthritis, and actually there are some very interesting data that are coming out now that suggest that an increased BMI may be a risk factor for developing psoriasis. So this is more common in psoriatic arthritis. That could explain why these patients with psoriatic arthritis get higher ALT levels during methotrexate treatment. And this is something that has been replicated in many different studies. This is a recent study by Curtis and al. From the US that showed that an elevation of more than 1 time the upper limit of normal occurs in about 1/3 of patients with psoriatic arthritis, compared to 22% of patients with rheumatoid arthritis. But if you look at patients who had more than twice the upper limit of normal, the percentage was very low. There was 0% for psoriatic arthritis and 1% for rheumatoid arthritis. And so could that be to other factors? And what are these factors that can cause elevation of ALT in patients who receive methotrexate? In the same study by Curtis and al., you can see what are these factors induced to diseases. If we concentrate on the right for psoriatic arthritis, we can see that the dose of more than 10 milligrams per week is a risk factor. An increased BMI, as we said before, is a risk factor for ALT elevation. Obviously, a history of an underlying liver disorder and alcohol use. So these are the most important factors that determine the increase in ALT during methotrexate treatment in patients with psoriatic arthritis. So, as it happened in our case, we found that our patient had liver enzyme elevation in less than twice the upper limit of normal. So what do you do for these patients once you find that they have elevated liver enzymes? One possibility is to discontinue every time you find it elevated and recheck it in 1 month. Discontinue that only if the ALT is increased more than 3 times the upper limit of normal. The other possibility is discontinue and not starting it again. And the other possibility, of course, is not to continue the medication without rechecking the AST and ALT levels. So what are the recommendations regarding this? And again, there is some variation here. If you look to older guidelines from the ACR from 2002, and you look to the newer one from 2008, and at the 3-year recommendation. There is one thing in common, of course, that once you have elevation that exceeds the 3 times the upper limit of normal, you have to discontinue the drug. And it appears that if you have an elevation between 1 to 2 times the upper limit of normal, you can repeat and adjust the dose. You can repeat the check or adjust the dose and do that accordingly to the results. And there is a gray zone between 2 to 3 times the upper limit of normal. So what happened to our patient? In our patient, the AST and the ALT levels were repeated in 3 weeks, and they were still found to be elevated at 45 and 65 units per liter. So at that point, our patient had an ultrasound of the liver that showed steatosis, fatty liver. He had a metabolic profile performed, and his blood glucose, HDL, cholesterol, and triglycerides were normal. So what were the risk factors of our patient for fatty liver? It appeared that the risk factors were obesity and the alcohol use. So the patient was advised to lose weight and repeat his aminotransferases in 2 months. That was done, and actually on repeated testing, his AST and ALT returned to normal. They were less than 40 units per liter. So the patient continued methotrexate. After he reached 3 years of treatment, he presented to us with an exacerbation of his arthritis involving now more joints. So the methotrexate was increased to 20 milligrams. That was given now subcutaneously, but the patient did not respond. So at that point, he was considered a methotrexate non-responder, and adalimumab, monoclonal antibody against tumor necrosis factor, was added at the usual dose of 14 milligrams subcutaneously every 2 weeks. The patient returned 6 months later, and at that point now, when he had his regular liver enzymes, now his liver enzymes were really elevated. His AST was 100 and his ALT was 250. And at that point, he had a workup performed in our clinic for hepatitis B and C. The antibodies for hepatitis C were negative, but the surface antigen was positive, anticore was positive, and the protective antibodies were negative, and he was E antigen negative, anti-E positive. And he had the serum HBV DNA performed that was really elevated at 65,000 units per ml. So these results show that the patient had what we call chronic hepatitis B, and that was E antigen negative. So now we have a patient who has chronic hepatitis B. He's taking methotrexate. So what should you do next? One possibility is to discontinue everything and just observe the patient. The other possibility is to start an oral antiviral agent and discontinue anti-rheumatic drugs, all anti-rheumatic drugs, both adalimumab and methotrexate. The other possibility is to start an oral antiviral agent, discontinue methotrexate, and continue just adalimumab. And the last possibility is to continue all the medications and recheck his aminotransferases in 1 month. So what should we know about hepatitis B virus infection? First of all, we should remember that this is a global health problem. There are about 350 million chronically infected patients worldwide. In the U.S., recently it has been estimated that about 700,000 people live with hepatitis B infection, and this is the leading cause of cirrhosis and hepatocellular carcinoma worldwide. And it has been estimated that around 600,000 deaths occur annually from chronic hepatitis B infection. So this is a problem, especially in developing countries in Africa and East Asia. How do you diagnose hepatitis B infections? Sometimes it appears complicated, but really it's not so. The only thing you have to look first is the surface antigen, as you see on the left side. Once you have the surface antigen positive, that means that your patient has an hepatitis B infection. Most of the time, this is a chronic infection. Very rarely you come across a patient with acute hepatitis B, and you can diagnose that looking at the IgM antibody against the core antigen. The IgM anticore in acute infection, in acute hepatitis, this is very high. Now, if your patient does not have the surface antigen, that means that either he's not exposed when everything is negative, S, anticore, and the S, as you see in the first line. If the S and the anti-S and anticore antibodies are positive, that means that this patient has a past HBV infection. If only the S is positive, that means that most of the time the patient has been vaccinated against hepatitis B. And if only a cord is present, most of the time, again, that means that the patient has a past infection. Rarely, this patient could have what we call an occult infection. You do not have the S antigen in the circulation, but if you look for HBV DNA in the serum or most commonly in the liver, you can find it. But this is, I would say, rather rare. So what is the natural history of the infection? First of all, we have to remember that some patients with chronic infection can have the E antigen, and if at during the first phase of the disease, usually in patients who are younger, you can have normal ALT levels, the E antigen is positive, and the DNA is high, but these patients do not have inflammation. You worry about patients who are E antigen positive, who have high HBV DNA levels, and have what we call E antigen positive chronic hepatitis B. These patients, like the ones who do not have the E antigen but have again elevated HBV DNA levels, the E antigen negative chronic hepatitis B, very often they progress to cirrhosis and then to hepatocellular carcinoma and death. But if you look at the general population, or if you look at the large populations of patients with hepatitis surface antigen positive, most of them belong what we call to the inactive carrier state. These are patients who have normal liver enzymes, who are E antigen negative, and they have low or undetectable HBV DNA. These are what we call inactive carriers. And these patients actually have a very good prognosis. They do not progress usually to cirrhosis or to hepatocellular carcinoma. So why do we worry about anti-TNF use in these patients? We worry because we now have enough evidence from patients that have not received appropriate antiviral prophylaxis that had a serious reactivation of the disease once they were started in anti-TNF therapy. In a recent review of the literature, Perez, Alvarez, and al. Showed that about 40% of patients developed HBV reactivation, and among them, 15% had acute liver failure, and actually 4 of them died. For patients who had past infection, who were only anticore positive, a small percentage, less than 5%, actually developed HBV reactivation. So this is a real problem, and we have always to take that into account when we start anti-TNF agents. Now, if you have a patient who you know that has HBV infection, can you start anti-TNFs? Actually, the American College of Rheumatology said that if you do not have advanced liver disease, that means if you do not have cirrhosis, you can use these medications with antiviral treatment. This is a level evidence C, and this was published in the most recent 2012 recommendations of ACR. So what are the recommendations? What you should do? First of all, you have to screen these patients before starting anti-TNF treatment and not holding that as was done in this case. So what do? You check for hepatitis surface antigen, you check for the anti-core and anti-S antibodies. If your patient has the surface antigen positive, that means he has a chronic infection, as we can see on the left side, and this patient should start antiviral treatment. And these days, we prefer agents who have a low resistance rate, like tenofovir or entecavir. If the patient has not been exposed to the virus, we should consider vaccinating these patients, especially high-risk patients. If the patient has anti-S antibodies only, that means that he has been vaccinated and you don't have to worry about this patient. And the most difficult group is the one that has anti-core antibodies without the surface antigen, which, as we said, most of the time means that the patient had in the past infection. What should you do in these patients? Because now there are some evidence that some of these patients can reactivate the virus during treatment, you can check the HBV DNA before starting anti-TNF. If the patient has HBV DNA in the serum, you should use oral antivirals. If not, you follow this patient very closely, and if the S antigen or the HBV DNA become positive, then you should start antiviral treatment. And how about HCV infection? This is a much more common disease in developed countries. It affects about 2.5% of the global population. There are about 180 million infected worldwide, and there are about 35,000 new cases in the U.S., and the same numbers approximately in Europe every year, and about 3 to 4 million in the world every year of new cases of hepatitis C. And how do you screen? Here the things are a little bit easier. You look for high-risk patients like IV drug users, patients who had been transfused with blood or blood-derived products before 1992, patients with high-risk sexual activity or healthcare workers, and you order the anti-HCV antibodies. If they're negative, you don't have to worry about that. If they're positive, you look for HCV RNA. If it is negative, this is a resolved infection, and you don't worry about reactivation. If it's positive, that means that the patient most likely has chronic hepatitis C. And what we know about the natural history of the disease, this is variable. It depends. We know that patients who develop chronic infection, about 15 to 30% finally develop cirrhosis, and among them 1 to 3% hepatocellular carcinoma after 20 to 30 years of the disease. Now, what about anti-TNFs in these patients? We do not have so many data on these patients, but in a recent literature review, we had data on 153 patients who had received anti-TNFs for about a year. Most of them, as you can see, had received etanercept, 110 of them. And in contrast to HBV, there was no significant effect on HCV RNA levels, AST and ALT levels, or liver function. And there were only 2 cases of confirmed or possible worsening of the liver disease during treatment. But we suggest that these patients are checked for hepatitis C before starting the disease, because sometimes these patients can have advanced liver disease and they do not have symptoms. And once you give them biologics, you increase the risk of other complications from the disease. So what happened to our patient? He also had a liver biopsy performed that showed, as you can see on the left, severe liver necroinflammation and advanced fibrosis and moderate fibrosis. He did not have cirrhosis. So what we did in these patients, we discontinued the methotrexate, as we said before. Once the liver enzymes are so elevated, or if there is a high risk of fibrosis, methotrexate should be avoided. The patient was started on tenofovir, an oral antiviral agent, and once his liver enzymes were normal, adalimumab was continued. During follow-up now, every 3 months of his AST and ALT levels, and every 6 months of his HBV DNA levels, everything is normal. So, to conclude my presentation, what are the main points to take home? What are the take-home messages? First of all, we have to remember that AST and ALT elevation in patients who have psoriasis or psoriatic arthritis may be due to other factors except methotrexate. And these include the variability of the test. You have always to remember fatty liver disease, and you have always to remember viral hepatitis B or C. The next point is that it appears that in patients who have psoriatic arthritis, metabolic syndrome is much more common, and you have to look for its components, and that could explain the reason why these patients sometimes they get elevated liver enzymes during methotrexate treatment. We know now there is a lot of evidence that has been accumulated that advanced fibrosis or cirrhosis during treatment is rather rare, but we should not forget to monitor AST and ALT levels every 3 months during methotrexate treatment. We do not recommend routine liver biopsy anymore in these patients, and you have always to remember to screen for hepatitis B and C before starting anti-TNF treatment, because as we saw in this case, HBV reactivation can be quite serious and cause a lot of different complications. And I would like to thank you for your attention. Thank you.
Thanks, Dimitrios. That was tremendous. You know, as I reflect on this, there are, 4 different kind of compartments that I think about. One, we still have to be vigilant about drug-induced toxicity, and methotrexate is still used in this disease, and we need to be hypervigilant. I think that for years rheumatologists thought that rheumatologists were just better, smarter, or more meticulous than dermatologists because we didn't see that much liver disease with the use of this drug. But I think that it's quite clear that the confounder by indication is probably fatty liver. Your comments on fatty liver are spot on and needs to be more on our radar screen. Finally, with regards to hepatitis B and C, hepatitis C actually, has its own place now. The new guidelines, 2012 update of the 2008 ACR guidelines actually make a recommendation for etanercept level C evidence for the treatment of rheumatoid, and I think we would extrapolate that to psoriasis quite easily. Hepatitis B, this is a disease where progress has been dramatic, and we have so many new drugs available. There's really no reason that this infection should not be detected. There's no reason that people with rheumatic diseases who have hepatitis B should not be put on effective prophylactic therapy or preemptive therapy, and there's no reason that these people can't be afforded aggressive anti-rheumatic care. So thanks again for contributing to the Fasenmyer educational effort. I'm sure you'll be back in the near future, and I know you'll be back in Cleveland in May of 2013 for the Biologics Summit.